lady who is a known case of type 2 diabetes mellitus for the past 3 years on oral hypoglycemic agent. She is presented with complaints of abdominal distension since 1 week, which is insidious in onset.
1 month abdominal distension.
1 month history of abdominal distension, which is insidious in onset, gradually progressive, associated with abdominal pain since 2 days, diffuse in nature, not associated with vomiting. Also associated with bilateral pedal edema and breathlessness. There is no oliguria.
Yeah. So we have a lady who is diabetic for 3 years, 51 years. It's an insidious onset of gradually progressive, abdominal diffuse in nature, not associated with vomiting, but also associated with bilateral pedal, breathlessness, and oliguria. Any other history you need, doctor?
Sir, this patient is having abdominal pain only since 2 days, which is diffuse in nature. Okay, sir. Then
she had abdominal 1 month. She had bilateral pedal edema, breathlessness, no oliguria, and she's got abdominal pain for 2 days.
As the patient is also having like abdominal distension, pedal edema, and breathlessness, I would like to know, is there any associated orthopnea or PND?
No, there's no result of orthopnea, dyspnea and exertion, or paroxysmal nocturnal dyspnea.
Is there any history of constipation or?
No constipation, no bowel, this thing.
Yes, sir.
Harish, in this context, will you ask for history of constipation? I mean, don't give a differential of gas, fetus, and all that. No?
Okay.
There's a patient who's got ascitis, you know that, and he's got edema with abdominal pain. So just hang on to that.
There's no obstruction.
No obstructive symptoms.
Goes on for 1 month. No?
Okay, sir. So this
correlate, no, she's got the abdominal distension with pedal edema and mild breathlessness, but she didn't have any. You wanted paroxysmal nocturnal is not there. There's no orthopnea, but there's no oliguria. But she's got abdominal distension and bilateral pedal edema, which is going on for 1 month, associated with abdominal pain for 2 days of origin, which was diffuse in nature.
So
what are the causes of diffuse abdominal pain for 2 days? I think that's the crux. No?
So considering the ascites and development of abdominal pain, which is diffuse, first I would like to think of spontaneous bacterial peritonitis.
Good.
Other differential is I would also like to think of any venous thrombosis, like splanchnic venous thrombosis.
Good.
Then, although not diffuse in nature, we would also keep in mind like background of cirrhosis, HCC also we have to keep in mind. Considering the abdominal pain. But pain usually will not be diffuse in case of HCC.
Any other questions you want to ask? What are the things you would like to ask? One is it orthopnea? You wanted PND, and urine output is normal without diuretics. Would you ask me history of paracentesis? 1 month. No, is it progressive?
Okay.
Is it slowly progressive or is it rapidly progressive? Did she require repeated paracentesis?
Yes, sir.
Yeah.
Any intervention has been done or whether previous
paracentesis? Intervention in the sense
of
just paracentesis. Yeah, basically just want to know that. If they give you some information on the color, they give you some more information on how frequent, what's this frequency related to? Supposing she has a paracentesis day 3, and then again within 2 days she needs 1 more again, and it's large volume. What are the possibilities with no oliguria?
Then we have to think of refractory ascites is one possible. Like
they'll have oliguria, no? Hi, Shobna.
And
Shobna, you can interact.
If
you're muted, Shobna.
If the patient is not.
LBK Shobna has joined us.
Madam, good evening.
Yeah, good evening, Shobna.
Good evening.
Nice to see you.
Yes,
Yeah,
yes.
you can.
Actually, I'm going to put my video off so that I can listen with concentration. Okay.
Either way, whichever way is convenient to you, no problem.
Yeah. Okay. Okay. Thanks.
Yeah.
Patient
Harish.
patient requiring repeated paracentesis. First, we would like to see the compliance, like sodium restriction compliance. First thing we have to look.
What are the other causes? One is liver disease related. What are the other causes? No, you can have repeated paracentesis. When can you get? One is in Budd-Chiari's, They'll have a rapid reaccumulation of flow tract obstructions, but the output will be near normal because they don't go through the same pathway as in a regular kindergarten case of cirrhosis liver. Okay, so that is important. So that is one. And then, of course, you said refractory ascites, and more important was the other conditions.
We don't know whether she has become refractory because this is the first time she is presenting. So the pain here, as you said, could be SBP, it could be mesenteric vein thrombosis, Budd-Chiari, and remember sometimes hemoperitoneum. Okay. What are the causes of hemoperitoneum in a chronic liver disease?
Ruptured ectopic varices.
Ruptured mesenteric varices is one.
And sometimes, like overlying any malignancy, HCC can rupture.
Ruptured HCC, subcapsular HCC can rupture, can produce hemoperitoneum. Sometimes even your iatrogenic, iatrogenic also can produce hemoperitoneum. So these are the causes. So sometimes you can think of hemoperitoneum, SBP, mesenteric thrombosis, and of course HCC, Budd-Chiari. Okay.
And other tumors like adenomas, they can also vascular tumors.
But adenoma will not come with ascites.
Ascites, yeah.
Okay. Can we go to the next slide? Madam Shobna, madam, is not.
No, she's around. Shobna, anytime you can ask questions. Yeah, continue.
He was. Then one moment she saw the abdominal, she went and took some Ayurvedic medicine for 1 month. Okay.
There is a history of CAM intake for abdominal distension for 2 weeks, 1 month ago. So I would like to know if there is any further worsening of the distension after intake of CAM.
Her pedal edema worsened and her abdominal distension worsened. She said abdominal distension worsened and pedal edema. That's why she was brought in here. And she's also a known diabetic for 3 years. Okay.
Yes, sir. Probably any drug-induced liver injury over a background of cirrhosis we can think of in this case.
Maybe worsening of the chronic liver disease due to a CAM intake. Okay.
There is no history of jaundice, GI bleed, fever, vomiting, loose stools, or cardiorespiratory symptoms.
Harish, what type of liver injury would you get with CAM to cause worsening of ascites? What type? Is it hepatocellular? What do you think is the type? It will be more like veno-occlusive. It has to be something worsening, so it has to be more of an occlusive pathology rather than a hepatocellular.
So you can have a sinusoidal obstruction syndrome.
Sinusoidal obstruction syndrome, yeah.
Veno-occlusive disease, which can produce worsening of only the ascites in these patients.
Okay. Yeah.
Yes.
Okay. So there's no bleed. There's never a history of jaundice. There's no fever, vomiting, loose stools, and cardiorespiratory symptoms. Can we go to the next slide?
Past history. There is no history of similar complaints previously. She was evaluated elsewhere in May 2022. Ultrasound abdomen shows chronic parenchymal liver disease, moderate ascites, mild splenomegaly, no space occupying lesion, and no thrombosis. Upper GI endoscopy has been done, which showed grade 2 to 3 esophageal varices with red signs for which banding has been done.
Banding was done. This was done elsewhere, yeah.
Yes, sir.
So what does it confirm up to here?
There is a chronic parenchymal liver disease along with portal hypertension, which indicates
cirrhosis. No? Do you think it's cirrhosis or non-cirrhotic?
It is cirrhosis, ma'am. Cirrhosis.
Ultrasound abdomen check. There is a chronic. We just got a report saying it's chronic parenchymal liver disease, moderate ascites, mild splenomegaly. There's no SOLs, no thrombosis, but she had grade 2 to grade 3 varices, which red sign thing. But she has never bled. And she has come with a progressive ascites now. Okay. And she says she never had jaundice earlier.
So how do you explain the pain now? Could still be SBP, no?
Yes, ma'am.
Thrombosis is out. Thrombosis is unlikely or less likely. Of course, further imaging may help us. But otherwise, now the pain will be more related to an SBP, no?
Yes,
Likely.
It's a very diffuse pain for 2 days, origin. That's why she came to us. Worsening ascites, worsening pedal edema, no oligomer, diffuse pain. So she came to us. And this was the thing which we had.
okay.
Any other questions you need? Anything in the past history, what you routinely ask in a chronic liver?
I'm here, Jayanti.
Yeah, you can ask few questions.
So what I wanted to know, Harish, is that in a patient with chronic liver disease and pain, so this ultrasound says no thrombosis. I think Dr. Jayanti mentioned that other imaging would be required to confirm it. So how good is an ultrasound to diagnose thrombosis of portal vein?
It is not a sensitive thing, ma'am. Better imaging modality would be a CECT abdomen to find the.
When you answer like this, you'll have to give percentage, no? You cannot say it's less sensitive or more specific. You would be very specific. A good Doppler is all that you need to make a diagnosis. No? Doppler would be an ideal investigation.
Okay.
No?
Okay.
So when a question like this is asked, you must tell how sensitive it is or how specific is it for picking up a thrombosis. So what do you think would be the answer?
Around 70 to 80, ma'am. I'm not sure exactly.
Okay. Pick up rate.
Yeah. So it's about that. So if even with Doppler, so that's why instead of CCT, you should first order a Doppler because it is non-invasive. Only thing you need a very good ultrasonologist to do it to be able to recognize that this is an acute portal vein thrombosis. Okay.
Okay.
Okay. So move on.
Yeah. Can we go to the next one?
Sir.
Yeah. Any other history you would like to ask? Can you go back to the previous slide, please? Yeah.
Past history of any jaundice in the childhood?
No, there's no previous history of jaundice. There was only some CAM intake. Yeah.
Any recent prodrome before the onset of?
No, there's no prodrome. There's no prodrome. No, you need to talk about the nutrition history.
In absence of jaundice, I don't think you'll ask for prodrome. No? What are the other things? 51-year-old lady. What are the other things that you'd ask? Menopausal history, very important, no? Menopausal history is very important because these are the patients who may sometimes they're put on this replacement therapy and then they have worsening of symptoms. So you must sometimes 51, 52 years, there's always a delayed menopause in some women. So that history is important in this patient. But there's sudden worsening.
Any other
like to ask for loss of weight, loss of appetite, fatigue, performance status,
loss of appetite, anorexia,
joint pain, arthralgia. Is she able to carry on her day-to-day household work, or is she sleeping most of the time during the day? No, all these things.
All these things have to come.
Yeah.
Does she have any symptoms of encephalopathy? Did she have any history suggestive of exposure to a chronic viral hepatitis? No.
Family history.
Family history of liver disease. All those things need to be asked.
Tattooing.
Don't worry about these slides. If we give a case like this, let us know what are the other history you would like to take in this patient, isn't it?
So in a 50-year-old, Harish, you must in 50-year-old lady, you must always ask about how many children she has, whether any of them were delivered by an LSCS, whether she received any blood transfusion. Oh, so you have that history already. Sorry, I didn't get that. So you have to ask for all that.
All these things.
Tattooing is something, with the newer tattoos, I don't think they really penetrate the skin. And with the recent only new needle the reusability of needles has decreased. So all those factors have also gone down, except in drug addicts.
Sure. Same syringe.
So you need to ask any history in pertaining to the etiology as well as any complications. Okay, we always said there's no bleed, there was no melena, there's no hepatitis. Did she have encephalopathy? Did she have any confusion? Did she have anything? Either did she have an overt encephalopathy or there are features of a minimal hepatic encephalopathy? All these things have to come. So once you finish all those things, then you should check the nutritional history, isn't it? As Madam said, family history. How many children did she have? How did she deliver? Did she have any blood transfusion? Did she have a dental extraction? Any risk factor for chronic viral hepatitis? 51-year-old lady, again, autoimmune is a possible. I mean, Madam was telling about fatigability, arthralgia,
Joint
alopecia,
pain, rash.
arthralgia, all those things. Okay.
Yes.
These slides are just given to you so that we have everything, but you should ask us what are the other things you need to do. Okay.
Yes.
On examination?
Did she have any pruritus? Isn't it? You never asked this. Isn't it? Now let's summarize, please. Can you summarize?
Yeah. Summarize before you go to the examination. Syndromic.
51-year-old female with a background history of diabetes for the past 3 years, presented with progressive ascites, which is
progressive abdominal distension,
abdominal distension with pedal edema, and associated abdominal pain for the past
diffuse abdominal pain for 2 days duration.
2 days duration, without any other signs of hepatic decompensation or with a performance status,
with a history of
Encephalopathy.
can intake for 2
You have
weeks.
to mention variceal bleed. You have to mention all the negative points. Very important. Yeah.
no,
With a performance scale, and you have to tell what's the performance scale at the end. So that will be your complete summary.
yes,
So what do you think is a possibility?
First, I would like to think of spontaneous bacterial peritonitis.
No. Give a complete diagnosis, doctor.
We need to give a syndrome. Here is a 15-year-old lady who was a diabetic for 3 years, presented with progressive abdominal distension and pedal edema, with no oliguria, with a diffuse abdominal pain of 2 days duration. She had no history of any jaundice, bleed, encephalopathy, or risk factors for chronic viral hepatitis. Okay.
So,
and she has no features of did not have any historical evidence of any decompensating heart disease. So now, in a 51-year-old lady who has come with a progressive abdominal distension, with pedal edema and a diabetic, and with a 2-day onset of pain, what is your syndromic diagnosis and what is your differential diagnosis?
syndromic diagnosis is chronic parenchymal liver disease, which is cirrhosis, with features of portal hypertension in the form of ascites
And ultrasound evidence.
and soft splenomegaly. And
endoscopy showing that you've got all the information. So
Yes,
now you can straight away say it's cirrhosis with portal hypertension, with decompensation.
With complicated by spontaneous bacterial peritonitis.
Possible. It's only a possibility.
And
Etiology.
I would like to think of give a differential diagnosis. First one is non-alcoholic fatty liver disease, considering the patient's background history of diabetes.
3 years of diabetes, and we do not know we have got any abscess. We didn't have an overt history that she had something like a metabolic syndrome earlier.
Okay. So other possibilities include chronic viral hepatitis and autoimmune
No,
hepatitis.
chronic hepatitis will be
Sir?
Hep B and
hepatitis B or C. Also, I would like to think of autoimmune hepatitis, considering 50-year-old female.
then what else you can think of? What is the other differential diagnosis we always include in a chronic liver disease?
Drug-in.
No, here you have said there is a decompensated chronic liver disease, there is cirrhosis of liver, there is hypertension. You said one is NASH related cirrhosis. Number 2, you said hepatitis B, hepatitis C. Number 3, you said autoimmune. Number 4,
Budd-Chiari syndrome.
but here is another thing you will always consider in a chronic liver disease.
Hmm.
Can it be a diabetic cardiomyopathy? Short, we do not know. We've got a history of 4 years. Is it possible that she's got long-standing diabetes? So just be like, when you ask for orthopnea, dyspnea and all, no, just keep that in mind. One is portal hypertension related POPH, portopulmonary hypertension, as well as hepatic hydrothorax, and you have a diabetic cardiomyopathy. Just keep all these in mind when you're thinking of the breathlessness. She gives history of breathlessness. Whether it's tense ascites causing breathlessness, we do not know. We have not done the examination as yet. Yeah.
You can also think of pleural effusion.
Yeah, so in your differentials, you have to give a DD for the breathlessness. No, we missed on that. Pain has to be discussed, but breathlessness, you have to consider the possibility of the tense ascites mechanical, hepatic hydrothorax, POPH, HPS, cirrhotic cardiomyopathy, and diabetic cardiomyopathy. All these 6 conditions can all present as breathlessness. Yeah, so just keep that in mind.
Yes.
So, I mean, when you give your final, the breathlessness has to be sorted. Your first investigation will be a chest X-ray, to be 100% sure that you're not missing a Anything else, NVK?
Nothing, ma'am, actually.
Differentials, I think. Shobna, can we move on?
Yeah, so just a quick thing for you, Harish. When you look at the background histories of all these patients, the patients who present directly with portal hypertension and SBP, maybe any of the viral hepatitis, NASH, autoimmune hepatitis usually does not present directly with decompensation and ascites. At least that's my experience. Maybe Jayanti, you can add that.
Yeah,
Autoimmune hepatitis has background symptoms prior. I mean, they have either jaundice or some kind of joint pain.
Joint pain.
They don't come directly with decompensation.
Agree to that.
Okay.
NVK, we move on?
Yeah, ma'am.
On examination, sarcopenia is present. Patient is conscious, oriented. Pallor is present. Bilateral pedal edema is present. There is no icterus, clubbing, cyanosis, peripheral lymph nodes. Blood pressure is 110/80 millimeters of mercury. Pulse rate is 86 per minute. BMI is 26 kg per meter square.
You should know to calculate the BMI in relation to ascites and pedal. Okay.
Corrected BMI we have to
any icterus. She had a bilateral pedal edema. She had pallor. Okay, there was not, but she was quite malnourished actually. Okay, can we go to the next slide, please?
Perabdominal examination. Perabdomen is soft. Abdomen is distended. There is shifting dullness is present. Mild splenomegaly. Bowel sounds are present. Cardiovascular system examination. S1 and S2 is present. Respiratory system show decreased breath sounds in bilateral infrascapular areas. CNS exam, there is no focal neurological deficit.
And there was no evidence of encephalopathy. There was no flap or any evidence of. So you need to complete the CNS examination by looking out for the minimal hepatic encephalopathy, all the changes, mini-mental
status examination.
And you should know all the tests for the minimal hepatic encephalopathy. There will always be questions about how do you classify hepatic encephalopathy. Kindly go through clearly the Western Haven classification. What is overt, what is minimal, what is ABC, what is episodic, what is persistent. All these things have to be answered correctly, okay, in the examination. So all she had was ascites and she had a splenomegaly. There was no jaundice.
Any visible veins, NVK?
No, there were no visible veins. There were no veins.
Are you surprised? No veins? No veins, only ascites. Small spleen.
Usually, veins, visible veins can be present in the anterabdomen wall.
In its absence, I'm asking, no? There are no visible veins in this patient. So it is possible if they're subcutaneous and the patient's got subcutaneous edema. You may not
You
see
didn't have
veins.
large veins in the back or.
But the presence of a spleen with ascites is cirrhosis, number one. You already have evidence of portal hypertension by endoscopy. You also have some evidence to say that there's portal vein that's abnormal. So you have some information there to say that she has an underlying chronic liver disease.
She had one ultrasound.
Any change in your diagnosis after examination?
Any change in the syndromic diagnosis?
No, ma'am.
So you feel still this is decompensated chronic liver disease, cirrhosis of liver, and she has got evidence of portal hypertension as evidenced by ascites and splenomegaly. Past
In
is
a patient with shifting dullness, how do you assess the liver span? And if something else is also missing here, you had some differentials in your. How do you look for a liver span in a patient with ascites? You put the patient at 45 degrees. Put the patient at 45 degrees. So what happens? The fluid comes down. The liver cell will at least get the upper border. The upper border is more important. The lower border may not. It may merge with the ascites, but the upper border. What's the importance of upper border? Liver dullness.
Upper border of dullness, like in case of
it's in the fourth space, then. So one, there can be hepatic hydrothorax, number one. So they do ask you questions on tidal percussion. These questions are asked. And number two is, when you get an upward enlargement, in patients with liver abscess, patients with hepatocellular carcinoma, you always get an upper. So the moment you get an upper dullness in the fourth space also, always think whether there's a SOL. So this question is asked, so always make the patient lie down in the 45 degree. If it's tense ascites with fluid fill, it's impossible. But if the patient's got shifting dullness, you can still put the patient in the 45 degree, then allow the fluid to gravitate down, and then you may get the upper border. I'd say the lower border is merging with the ascites. Okay? Yeah.
So Jayanti, can I say something? In this patient, one of the things that you must look for is the hepatojugular reflux.
And HJR, that's what I said. One is missing here.
But was one of the differential diagnoses that.
Yes,
so always look at the hepatojugular reflux. You might come up to be very surprised, You're kind of incidentally examining, suddenly it's there, you might find something else. Please look for it every time.
And in the examination of ascites, you need to talk about shifting dullness as Matt said, also talk about the drop space, and always look for hepatic hydrothorax on both sides. Okay? Look for the fluid obstruction on both sides, right? Yes. Drop space is something which you need to mention. Okay?
Yes.
So the end of the end of the clinical examination, your syndromic diagnosis remains the same, and you consider the same etiology.
NPK, any tenderness?
She didn't have any tenderness, man. She didn't have any tenderness. There was a diffuse abdominal pain. There was no rebound tenderness.
Okay, we can go to the investigations. I think the diagnosis remains the same.
And what is the cause for pain? You think what will be the cause for the pain? She came for 2 days.
This patient likely it is spontaneous bacterial peritonitis.
Probably spontaneous bacterial.
Still, we have to rule out outflow tract obstruction.
Unlikely.
Portal vein thrombosis or what we had ultrasound was earlier was done outside. Okay, she got it done somewhere in Kerala. So, shall we go ahead with the investigations?
So just tell line of investigations. What all do we need?
What do you want first,
Abu Bakr, I think we'll just ask him. Abu Bakr, you can take over. What all investigations you need? Abu Bakr, you were there?
Yes.
Yeah. Just tell investigations that you need.
Complete blood count.
And keep telling why you want the test, okay? Quickly. Bhargav, just hold on to the investigations.
To look for anemia, platelet count.
Keep your video on. Please keep telling. Be fast, yeah. So you need a CBC. Next.
Yes,
someone is snoring. Okay.
Yes, sir. LFT.
Can you mute that person, whoever it is?
Yeah, someone is snoring away to go.
So we
Please
can-
mute participants who are not, except for the
Madam,
faculty, all the others.
Madam,
mute.
nobody is snoring. That's my pet dog, ma'am.
Oh, that's snoring now. Sleeping.
Okay, it's your,
No problem, don't
He
switch
can't-
off. Don't switch off your.
I can't send him off.
No
He
problem.
always holds on to me when I'm sitting here.
No problem. Continue.
no problem.
Don't mute.
Ajay,
Okay, continue. No problem, LBK. Come on, be quick.
Liver function test.
No, 1 minute. 1 minute, Harish. First of all, when you look at the CBC,
yeah, look at
and
this.
the patient has macrocytosis.
Macros.
So there is macrocytic anemia. There is
Look at the
ESR which is
hemoglobin.
high. The CRP is positive.
CRP
This
positive.
itself gives you an idea of something. What is it?
And ESR of 120.
ESR of 120, CRP positive. She's got a hemoglobin of 76. Look at the platelet, 2.37 lakhs.
The MCV is 78. So
Yeah,
why
but
is macro?
I don't know, madam. That came in this one, but the pathologist said there was a macrocytic normochromic anemia. MCV is 78. Platelets were 2.37 lakhs.
So that's a good platelet for a portal hypertension.
Yeah, good platelet count and a PTINR of 1.05. Hemoglobin is 7.6. ESR is 120. CRP positive.
Can be
audio problem.
No, I can hear. I don't know what's happening. I can't hear.
Yeah, we
Harish.
can hear. We can hear.
Yeah, now
Ma'am,
it's okay. Now it's okay.
Yeah, tell me, Dr. Abubakar, what do you think of this? Or Harish, Dr. Harish?
sir, with the elevated ESR CRP and elevated platelet count for expected for this patient, we think of some inflammatory process, usually infective.
So in a patient with cirrhosis, if there is any acute inflammation, does the platelet count go up?
We tend to see it fall down, ma'am, usually.
Yes, so that's what.
Yes, ma'am.
So why is the platelet count normal? The WBC also is not that abnormal. It's okay. It's 1,200 is very good.
They're not saying it's snoring, ignoring. It's snoring, just take him.
So there's only anemia, no? As per this, there's only anemia. WBC is normal, platelet is normal, but you had evidence of portal hypertension on imaging.
So even INR is normal.
Even INR is normal.
Yeah, so that is also a little surprising given the amount of portal hypertension the patient has.
So what's the next investigation you want?
We would like to do an ultrasound abdomen with Doppler repeat.
Liver function?
Ask liver biochemistry, no? You ask for liver biochemistry.
Okay.
Can we have the next slide?
Total bilirubin is 1.3. Direct is 1. AST and ALT are normal, which is 30 and 15. Total protein is 7.7. Albumin is 3.2 and globulin is 4.5. There is a AG ratio reversal. Gamma GT is 100 and alpha is 256.
Normal alpha here for us is 129. Gamma GT is 66. Normal.
So both are elevated.
Alpha is 2 times elevated, around 2 times.
So it's got a normal bilirubin, almost near normal transaminases. AG reversal. What do you think about globulin?
Globulin is elevated, sir. 4.5.
Albumin is not too bad. Albumin for this liver is not too bad. It's
Not
okay,
too
3.2.
Albumin is 3.2.
So what's your thought process? With an ESR of 120, remember the ESR there, 120.
Like to think of infiltrative disease.
Granulomatous,
Granulomatous.
granulomatous disorders, lymphomas, tuberculosis, everything is in mind. Or any SOL, say HCC, any of these would cause an isolated rise in gamma GT and alphas in the background of a patient with liver disease. There's disturbance from your side.
Anything else you want?
No, there's no disturbance here. Is there disturbance from my side?
No.
Okay.
Some audio. I don't know. There's a lot of wind and rain, man, here. Okay. So where we have only.
I kept my window closed. There's no rain.
Not from your side, man. Generally. Total protein albumin is not too bad. Gamma GT is 100, alphos is 256. Okay.
In a patient with chronic liver disease, with you must have read this, no? When the platelet count is more than 1.5, what are the things that cross your mind?
Myeloproliferative disorder.
MPN, exactly. Yeah. So
Myeloproliferative disorder is one thing which we need to think
to keep in mind, because it's something unusual, no? Moment. That in fact, the guidelines say, no, more than 1.5, start thinking of myeloproliferative MPNs. So you have to keep that in mind. So as you're working and you're moving towards, because now you're having a rise in alphas and gamma GT. Yeah. So is it some prothrombotic phenomenon?
She has got a normal PTINR for a lady who's got decompensation and varices. And she has got normal enzymes, and albumin is not too bad. Albumin has gone up. I don't know, the gamma GT and ALP is mildly elevated. As madam said, could be infiltrative, could be myeloproliferative, or something. She's taken CAM for 2 weeks.
CAM is there.
She has taken CAM for 2 weeks. That's also a possibility. But her bilirubin has never gone up. Her PTINR is normal.
Next imaging, what next investigation?
She has come with abdominal pain. What will you do?
I will do the parasitosis and ascitic fluid analysis.
The results. What do you want to see in the ascitic fluid?
I would like to see SAG ratio, sir. Then total.
What's the important thing you want to see in her? She's come with abdominal pain. A patient who's got a decompensated.
A neutrophil count greater than 250.
You want to look for SBP, isn't it? So actually, our counts were only. Her counts were 460 total count, and she had 80% neutrophils. She had protein of 0.8 grams and albumin of 0.6.
Okay. Serum albumin is 3.2 and albumin is 0.6. So that's a high SAG ascites and
high SAG low
protein ascites.
Possible SBP. She had around 460 cells and 80%.
80%.
Yeah, that was okay. Next. She's got a pedal edema. She has got no oliguria. You want to look at anything else?
Renal function.
Can we have the next slide? Look at this.
Urea is 103. Creatinine is 5.2, sodium 128, potassium is 2.8.
And bicarb?
Bicarb is 8.8.
So your comments on this, doctor?
Sir,
she's got chronic liver disease. She's got diabetes. She's got mild SBP.
Urea and creatinine both were elevated. I will think of acute kidney injury, probably over a background of maybe CKD also we have to keep in mind.
She's got a acute kidney injury. So what are the possibilities of acute kidney injury in this patient? What are the possibilities of kidney injury in this patient?
Sir, first is diuretic induced, any diuretic or any.
No, she was not given.
Not a diuretic.
Took a CAM and then came here.
Then the second thing is it could be HRS. It could
HRS
be,
AKA what?
It could be HRS AKA, sir.
Okay. Third.
Third thing is sepsis. Any associated sepsis or
SBP is there, no?
SBP is there.
Yes.
So that could have precipitated an acute
Uh,
kidney.
Uh,
She's a diabetic.
And CAM.
so, yeah, CAM intake is also there. That is
Yes.
also one more possibility.
Is there
And,
any other possibility you want to keep with this?
She's a
kind?
diabetic.
Diabetic
So what-
nephropathy, we can think of.
Okay.
So you must get a urine examined, no? For protein. Other
You have also said autoimmune, no? So you think it could be drug induced? It could be due to infection and BP and we need to rule out an underlying chronic kidney disease because she's also been diabetic. Even though she says about 3 years, many times in India we don't know how they don't realize that diabetic for so many years. When you go about the situation, you have a urea creatinine. Your registrar says, how do we go about from here?
I would like to do a urine routine examination. 24
Can we have
hour
the next slide, doctor?
urinary protein.
Next slide, please. Next slide.
Urine analysis. Albumin is 1+, sugar is 3+, blood 3+, with an RBC of 84, WBC 3, and no cast. Urine sodium is 36. Urine protein creatinine ratio is 1.4. 24-hour urinary protein is 1 gram per day. Urinary osmolality is 300 milliosmoles per kg.
You tell me, what do you feel about this urine?
There is albumin, proteinuria is there.
How is the urinary sediment? Is it active or non-active?
Actually, there
The urine PCR, urine sodium, and urine sediment. Tell it whether is it you think it is a HRS AKI or you think there's an intrinsic renal disease.
Sir, presence of proteinuria tells us that it is an intrinsic renal disease.
Possibly
It
she
has to be ruled
intrinsic-
out before diagnosing HRS.
Huh?
Proteinuria, presence of proteinuria tells us it is an intrinsic renal
Look at the
disease.
urine PCR is 1.4. Her urine spot sodium is more than 20. She has got active sediments in form of RBCs, WBCs. There are no casts. Protein is 1 gram. So that means she has got a intrinsic
Hepatic range proteinuria. There is an
she has intrinsic renal disease. Intrinsic renal disease. What could have been the causes here?
With the red cells in the urine, you should also find out other drugs that the patient may have taken, like NSAIDs. Because in a patient with cirrhosis, many of these patients who take NSAIDs can develop a papillary damage
Correct.
and occasionally a papillary necrosis.
can present with that.
Yes, they can have an IgA nephropathy. So this lady is diabetic, so we don't know whether how long she could be a diabetic nephropathy. Then, as Dr. Shobna Madam said, it could be an intrinsic renal disease, it can be an IgA nephropathy, or there are certain conditions which are associated with. What are the two conditions of the renal disease which are associated with liver disease? Membranous nephropathy. You have membranous proliferative glomerulonephritis.
NPGN.
So which are the in which liver diseases you can get MPGN and membranous nephropathy?
Chronic viral hepatitis.
You can get it in hepatitis B.
B.
You can get in hepatitis
Hepatitis
C. Where else? Where else can you get? Earliest papers came from Chandigarh from nephrology. K.S. Chip has written a paper on that. extrahepatic portal hypertension and sometimes with non-cirrhotic portal fibrosis because of the shunt nephropathies, you can get this. Okay? You can get this. Please read that. I think Shobna madam also think that K.S. Chuk's paper was this one, which that a lot of these things can happen. Okay?
Can she be having a multiple myeloma? The ESR was sky high.
Yeah, ESR is high
And,
CRP. It can happen even in a myeloproliferative diseases.
And myeloproliferative diseases. I think you should keep, because you've still not gone into the ascitic fluid analysis. Yeah? This is something that you have to keep in mind. Okay, can we move on?
Can we go back? And then because of intrinsic renal disease, they looked at this one. They looked at the C3, C4, both were low. And workup for CLD?
Viral serology, HIV, HVSAG, HCV is negative. Autoimmune workup, ANA is negative. ANA profile, AMA M2 is positive.
Liver IgG means we do LKM1, liver cytosol antigen, and soluble liver antigen. 3. Okay.
Negative.
These were negative.
Serum IgG is 14 gram per liter.
Is it normal or abnormal? Serum IgG. What is the cutoff? Above 16. Above 16. And what will be the usual range in autoimmune liver diseases? Serum IgG levels
is elevated. So 1.2 times.
1.5 to 2 times. It will be around 29 to 30. And how do you prognosticate treatment response on serum IgG? Supposing you treat autoimmune liver disease,
IgG should come
down. In what timeline the serum IgG should normalize to see that the patient is a responder, apart from the other things?
An answer, LBK.
By 6 months, it should become less than 12.
Okay.
Okay. That is what I think they'll expect from you. 6 months, they'll be expecting. We did ANCA profile because nephrologist thought it was an intrinsic renal disease and he had a proteinuria thing. So here in this point of time, how do I rule out it's not a diabetic nephropathy? It's a diabetic nephropathy.
You can look for other organ involvement, sir.
Correct. Excellent. So we looked at the fundus and fundus did not show diabetic
retinopathy.
So you want any imaging now? Can I have the next slide?
Ascitic fluid we have? Ascitic fluid?
Madam?
Ascitic fluid.
Yeah, madam. That's what I told.
Yeah, next slide.
So here the TSH is normal. Anemia, because she had a
NCV is low and
they said macrocytic normochromic. Ferritin was normal.
Iron is low.
Then what about transferrin saturation?
It's
more than 45%.
Yes. Elevated.
Yeah.
What's your comment?
And vitamin D was normal. Okay. B12 was normal. Some only iron was low. Vitamin D was low. TSH is normal. Okay. Can we go to the next slide, please?
Ascitic fluid analysis.
This is, we've gone through it. We've gone through this. Pleural fluid analysis. Okay, the pleural fluid is there. Patient is got pleural
fluid analysis is exudative. No SBE. ADA is 29.6. Gene expert is negative.
Cytology showed only chronic inflammation. Okay.
Blood culture, Klebsiella.
What do you expect the protein content in a pleural fluid? Probably in a hepatic hydrothorax, comparing with the ascitic fluid. Will it be the same? Will it be high or will it be lower? In hepatic hydrothorax, the protein content will be the same as ascitic fluid. It will be higher or it will be lower.
Same.
No, it will be slightly be higher, mainly because the pleura absorbs more water. Okay, the more water absorption is more inflow, so it will be slightly higher. Okay. And for any chronic liver disease, because she came with an SBP, we sent a blood culture. Which group? Klebsiella.
Klebsiella.
So we send 2 blood cultures, a urine culture, and ascitic fluid culture. Ascitic fluid culture did not grow anything. SBP got resolved with antibiotics. Can we have the next slide? Next slide,
Next
please.
slide.
Other workup.
Here the patient had, why did I do a serum protein electrophoresis?
Sir, globulin is elevated.
No, high ESR,
ESR.
anemia,
ESR.
high ESR, CRP was positive. And when we looked at the liver function test, they were not looking very too bad.
Very bad, exactly.
Isn't it? With so much of ascites and SBP. So we thought we should also, as you said, we thought of a myeloproliferative stenosis. And madam was talking about myeloma. So
M-band we can.
there was no M-band. We wanted a procoagulant workup because of the myeloproliferative disease. And everything was negative, including JAK2 was
Negative.
JAK2 was negative. Okay. Fundus examination, as you said, there was no evidence of diabetic retinopathy. Though nephrology said it may be still diabetic, but there was no diabetic retinopathy. So we were dealing with a patient who has got a chronic liver disease, normal bilirubin, normal INR, normal platelet count, with ascites and portal hypertension, and high ESR and protein. So what do we do next?
There's more towards the renal,
MPT.
more towards the renal problem rather than the liver. Unless it's a combination, actually.
Seems to be a
It's more like a
combination.
combination.
Go ahead. Can we do the next one? Next slide. We did an ultrasound. We couldn't do a CT. We did an ultrasound abdomen. Do you have the ultrasound report? Just see this. We did an ultrasound. Can we do next? Next, please. Yeah.
So ultrasound abdomen with Doppler shows chronic parenchymal liver disease, dilated main portal vein, mild splenomegaly, severe ascites with loculations. Intrahepatic portion of the portal vein is not visualized and is replaced by few collateral veins at the porta hepatis and splenic hilum. IVC hepatic veins are normal.
So the main problem, the extrahepatic was dilated. Intrahepatic vein they could not see possibly. There were a lot of collaterals, and in fact, there were a lot of collaterals. Actually, the sonologist said when we did a Doppler, there were a lot of, they could see the splenorenal collaterals. They could see hilar collaterals. They could see lenorenal collaterals. So all these collaterals were there. So what do you think? We could not do a CT abdomen because she had an acute kidney injury. So we could not have things. So
what is your diagnosis with
what
this?
is your diagnosis here? There is a chronic parenchymal liver disease. There's a dilated portal, plenty of collaterals with ascites. Just look back. Normal platelets, normal PTINR. LFT is not very bad.
First is portal vein thrombosis, sir.
No, there is a intrahepatic portal vein is just narrowed. There are a lot of collaterals. So you think she has had a parenchymal liver disease, or it's a portal hypertension which has driven the decompensation here?
More of portal hypertension driven decompensation
Hypertension
rather than parenchymal.
So which kind of portal hypertension has driven this?
Pre-sinusoidal, usually it will be NCPIH or
NCPIH? She has so many collaterals outside the liver.
But against, usually splenomegaly will be more, spleen will be enlarged more in case of NCPIH.
So spleen is more in NCPIH or in EHO?
NCPIH, ma'am.
NCPIH, okay.
So there are so much of collaterals, decompensation with almost near normal LFT, platelet count and all. So we thought of an NP. Madam?
Would you like to look at the hepatic veins here? That's not mentioned.
Hepatic veins mentioned.
Normal.
Hepatic veins are normal.
The last line. I didn't see the last line.
Hepatic veins were normal. So
Normal, okay.
So we also did a bone marrow because we were thinking of a myeloproliferative disease. It did not show anything like a myelofibrosis. Okay. Okay. And what do we do next? Can we go to the next slide? Which is on the slide? Endoscopy.
Post-EVL status, residual grade 2 to 3 esophageal varices with no red signs, severe portal hypertensive gastropathy.
Again, we went ahead and banded those because she had one banding 1 month back, so we again banded it. So we have a patient who has got.
Do we need a liver biopsy, you think, Harish?
Yes. Patient has features of severe portal hypertension, but liver function tests were not matching with this. They were almost fairly normal. So we can proceed for a liver biopsy in this patient.
Okay.
Because alphas and gamma GT was elevated, so I think you should go for the transjugular. No, ascites is quite.
So I think this is she had a ascites. So we went in for a
only thing was they mentioned it was loculated ascites. I was a little concerned about that.
One area they said loculated. We couldn't get a CT done on this actually.
No, that's okay. Yeah. So I think
next slide.
Go for a transjugular biopsy.
Can we go to the next slide?
Then in this patient, there is also a significant renal disease.
Yeah.
More of renal.
Yeah, that may have contributed to the ascites also.
Maybe.
Yeah, nephrogenic
There's got
ascites.
significant proteinuria. That's also could have contributed.
Nephrogenic ascites is a possibility.
Can we go to the next slide?
We just take up the questions. Let us just finish and then we take up the questions. Okay.
Can we go to the next slide, please?
Next slide, Babu.
So we did a transjugular liver biopsy.
Prehepatic pressure is 20, wedge is 40, hepatic venous pressure gradient is 20 mmHg, which is very high.
Can we go to the liver biopsy? Can we go to the next slide? Next slide, please. There are some pictures of it, I think.
You have some pictures on it.
Can you read that, please?
Bhargav, let's see if there are any pictures.
The next slide has got a picture, ma'am. There's some pictures. I think it did not come to me. There were pictures actually. You see, Bhargav, is any other slide which pictures? No. I think that thing went off. I think the pictures did not come, and there was some pictures.
Okay, that's okay.
Let me see. I can show it the next class, ma'am.
Sure. Yeah.
Biopsy showed marked portal fibrosis. Hepatocyte shows focal micro and macrovesicular steatosis. Sinusoidal dilatation is seen in parts of the section. Dense collagenous portal connective tissue contains multiple vascular channels exhibiting dilatation, thickening and hyalinosis of the wall and focal fibrous obliteration. Mild mononuclear cell infiltration is noted. Prognosis, features compatible with NCPIH.
Okay. So this is basically decompensated liver disease, which presented with ascites and portal hypertension. And you can see that she had a normal platelet count. But this seems to be driven by a portal hypertension, and this is not so. Somebody said the portal vein, intrahepatic small portion of the portal vein was not seen, or probably it was obliterated.
The rest of the portal vein is normal, so it's not
extrahepatic portal vein obstruction is not there because the main portal vein is dilated. That is a very classical feature of NCPIH.
Aneurysmal dilatation.
Look at this biopsy, very classical. Portal fibrosis, hyalinosis of vessels, obliterated portal vein. This is what we want to highlight. Can we go to the next slide? Next slide. Next slide. Anything is she was very decompensated, but the point of discussion is we need to think of the renal involvement in NCPIH. Okay, you can get sometimes besides proliferative glomerular nephropathy, IgA nephropathy. we couldn't really do a renal biopsy because of severe edema behind, and they were not. So, basically a patient of non-cirrhotic portal fibrosis, decompensation predominantly driven by the portal hypertension with small vessel involvement in the liver, and with a concomitant renal involvement in form of a proteinuria illness.
This how did the so-called AKI progress in this patient? How was it? I mean, it remained
What,
as
madam?
AKI. The AKI bit, was it AKI or was it more like a CKD?
No, madam. What happened once we started treating the SBP, the creatinine came down, and now it is stabilized around 2.8.
So it's still there. So it's gone for
It's
kidney
still
injury.
there, yeah.
Kidney injury is there.
Yeah.
At the end of 3
Ascitic was
months,
becoming refractory. You can't give diuretics.
yeah,
He was requiring only tap.
albumin.
But these people said this is an intrinsic renal disease. So if at all we need to salvage her, the only way is to do a simultaneous liver and kidney transplant.
But does she need a liver
We
transplant
thought
at all?
we do a TIPS, but TIPS will not work well in the presence of an intrinsic renal disease. It will not come down on that. We had sometime a very, very bad experience of TIPS. We thought can we salvage her by a TIPS, but no. So
In this particular patient, liver seems reasonably all right, So I'm just wondering.
she's becoming, because there is, as Madam Shobna Madam said, because there is intrinsic renal disease, the proteinuria was also contributing to the
Quite high, yeah.
ascites.
Yeah. So the management.
This is something what we need to do is simultaneous liver and kidney transplant, because many times I've seen for NCPIH with a small proteinuria, some people have done transplants. 6 months after transplant, you have put them on tacrolimus, the proteinuria has worsened. Now they have come back with ascites. The liver functions are very, very good. So I think in this sort of cases, when you have this one, it is we need to plan a simultaneous liver transplant. So, but don't say this first, but this is our plan, which these people have put it on the slide. But this is a case of decompensated chronic liver disease, predominantly a non-cirrhotic portal fibrosis. The points to ponder here are, she had a nearly normal LFT. She had no normal platelet. She had anemia. She had portal hypertension. And she almost have a very normal LFT in this patient. That's the time you think of.
Yeah, I agree to that. Yeah, I think it's more towards.
And there was the intrinsic renal disease. So you should know, differentiate. How do you differentiate intrinsic renal disease from a HRS, AKI based on the urine? That's all. So please know all the stages of HRS, stage 1, stage 2, stage 3, and this thing. So this is probably an NCPIH, may have mesangial-proliferative glomerulonephritis because of a lot of RBCs and all this, and very high proteinuria in these patients. Please read up Dr. K.S. Chuk's paper, which came in Kidney International way back in 1990 or 1992. Very beautifully written article of how he was the first to describe this sort of. What happened is, in All India Institute, when they used to do for AHPBO, this shunt surgery those days. At that time, when they did the shunt, most of these toxins were going into the kidney. So what is the pathology is, as you said, defective hepatic reticulocytation, where the bacterial toxins go and hit the glomerular thing because of the shunt, and then they develop a proteinuric illness. So I think this is a way, when you have something like this, you should. So highlights is this, that how do you recognize NCPIH clinically, and in the presence of renal failure, how do you differentiate from an intrinsic renal disease, and how do you manage this patient? And all.
Any questions in the chat box?
Please remember, in about 15 to 20% of all these patients, including NASH, you can have some of these autoantibodies positive.
Positive, yeah. AMA is not a...
She did not present like no primary biliary will present without any jaundice and all. She will come with pruritus for many months or years before she decompensates with jaundice. She has not presented like this. Okay.
Yeah. Bhargav, you have the second short case?
Madam,
Did you receive it?
Jayanti Madam and Shobna Madam, you can...
Yeah, you can add on Shobna. Any points? Bhargav, can you move on to the... Shobna, to add any points?
No, I think we've done almost everything. Only thing I cannot still explain the megaloblastic anemia. That's
NCPIH, but how?
I know, but that the B12 level is normal.
Normal.
Yes, serum iron, ferritin were okay. Transferrin saturation was
I need to check. Sometimes they come treated somewhere else. They would have got some shots of B12 and come also. I'm not very sure.
Yeah, possibly. So probably, we just have to repeat that. Yes.
Yeah.
NBK and
Yes,
Dr.
ma'am.
Shobna. This is a rapid fire, okay? For
Okay.
Amit and Amit, is it? Amit and Abu Bakr and Harish, all three can join. Bhargav knows the case. So I'll start presenting. Okay, move on, Bhargav. Shobna and NBK, please take over. So this is a 51-year-old male who presented in May 22, about 2 months back, with pain in the right hypochondrium, dull dragging, with history of cough with the cat or deep inspiration, history of fever with chills and rigors, and he was diagnosed as liver abscess and had a drain done on 2 occasions. Okay, next slide. On examination, he's middle-aged, BMI of 23, vitals are normal, cardiovascular respiratory system showed traps in the right base, and per abdomen, there was mild intercostal tenderness and scar of the drain. Okay, next slide. So, going through the lab investigations, the WBC was near normal, platelet was normal, INR normal. He was a diabetic, so blood sugar was 214. And like the previous case, we had a rise in alphas and gamma GT of 210 and 93 respectively. AST was normal and bilirubin was normal. Next slide. Okay, now take up Abu Bakr. Now we can have some discussion. What is the diagnosis and differential diagnosis in this chest X-ray? What is it that you're seeing? I'm giving you the history. Harish, you can also answer. Amit, Harish, Abu Bakr.
Subdiaphragmatic abscess, you can think of.
Subdiaphragmatic
Just describe the finding.
What you have to describe the finding
Yeah.
Here.
and give your differentials.
The heavy diaphragm appears elevated.
Yes.
There is blunting of right costophrenic angle.
Yes.
What else is there? There's a hump, no?
What is that hump?
Yes, ma'am.
You can see a hump towards the lateral side,
Yes,
to
ma'am.
the extreme
The
right.
right side, yeah.
So what are the causes of that hump? One is there can be a diaphragm weakness of the muscle, no, diaphragm itself. That's one. There can be herniation. Okay. And number 3, I've already told you that the patient has got a liver abscess, which has been drained on 2 occasions. So what is the possibility now with that background?
Iatrogenic injury.
Iatrogenic injury?
No, when there is a liver abscess and a pleural effusion, what are the causes? When there is a liver abscess on the right side, and if there is a pleural effusion, what are the causes of pleural effusion?
Amit, you want to try, Amit?
So why do patients of liver abscess develop pleural injury?
Pleural effusion.
It can be reactive, sir.
It can be sympathetic effusion in acute. Acute.
Yes.
There can
After
be
drainage, you suddenly develop pleural effusion. What is the problem?
Amit?
fistula formation.
Fistula.
What do you call that? You should give the nomenclature for that.
Systematic fistula. Amit? Amit, you want to try? Abu Bakr?
I'm not sure.
So what do you call that? It's not a fistula, it's a rupture, no? It's a rupture into the pleural cavity, no?
Somebody has said
Rupture of
it's a biliary pleural fistula. So biliary pleural fistula will not come like this. This is a localized hump coming on the lateral side of the right diaphragm. A biliary pleural fistula will actually have a pleural effusion.
So these are the things that should come to your mind when a plain chest X-ray is given. Next slide. Bhargav? Yeah. Now, this was the CT that we had. Can you describe what is seen here? Cross section. Patient also gives history of cough. So what is the possibility? The patient gives history of cough and you had an X-ray chest showing the other finding. What is the possibility now? What is it that you're seeing? It's glaring. Bronchial, But a bronchial fistula, so the patient can even have hemoptysis. They can have anchovy sauce coming out in this thing. It can be frothy.
Yes.
So you have to consider this possibility. You already have a history that there's an abscess. And then you can see one communication with the bronchus there, and that's
Yes.
one that suggested that there could be a hepatobronchial fistula. Okay. That is abscess communicating with the bronchus via the pleural cavity. Okay, next slide. Now can you describe? Amit, you can take up there are 4 sections here. You can just describe the findings. Quick, you have to be fast.
Liver shows a mass lesion, ma'am, with well-defined border.
You call this as a mass lesion, no? How do you just describe the lesion?
Describe that lesion.
What is this lesion called?
Hyperechoic lesion.
It's
Hyper.
echoic. When you say it's CT,
You
it
call
will be
it as
dead.
hyperechoic. You call hyperechoic in the CT.
Hyperdense lesion.
Hypo
Hyperdense.
or hyperdense? It's hypo.
Hyperdense.
It's hyper, huh?
It's more
Abu
black.
Bakr?
It's quite
Abu
black.
Bakr?
If it is
Hypodense
black, it
lesion.
is hypo.
It is hypo with rim enhancement. No? You can almost find a ring, and then there's a central hypodense lesion. Yeah, so that's what it is. And you can see in the lower one, you can even see it extending lower right. Lower right, you can see it going into the lung. It's just infiltrating there. Okay, next slide. What is this? What is this procedure? Amit. What is this procedure?
Drainage of the abscess, ma'am.
You have 4 slides there.
Percutaneous drainage of the abscess.
That's all. What else?
It is CT guided.
CT guided, exactly, yeah. CT guided.
Percutaneous.
What else is
Transfer.
happening?
Transhepatic drainage of the abscess.
What else is seen in the right lower quadrant? Right lower. Has something been placed there?
Pigtail placement.
Obviously, it has to be a pigtail, no? Because you should be able to pick up that finding there. The first one is
All
guiding, the
pigtail.
second is into, and the third one, and then there's one, I could not get the complete, but there was an end-on picture there showing that there is possibly a pigtail drain. Okay, next slide.
Okay, just a moment. You
Just
see
hold on.
this, all these plates of the CT, they show that the abdominal wall,
Arghab, go to the previous slide. Arghab.
see the abdominal wall in that region already has some defect. So probably that is the older site of the drain.
Yeah.
The wall is abnormal looking.
Yeah.
Even the subcutaneous tissue has that kind of appearance.
And
This is
like
probably, it's a bulge. So
Yes.
probably
Yeah.
that's the old drainage.
previous drainage.
Things. Yes.
Next slide. What is seen here on the chest X-ray?
You can see the pigtail.
Pigtail. So we can see a pigtail. So you should be able to identify that on CT chest. Okay, next slide.
And what else
Yes.
can you see? 1 minute.
Go
Just
back, go back. Go back.
See that hump in the right, in the lateral diaphragm area has disappeared.
Yeah, up in the drain. After the drain, it has disappeared. Okay, next slide. Yeah, can you just pick up something in this particular CT? So that was the liver. Something else is glaring at you here. Can any one of you just read out what are the things that are seen in this particular CT? Harish?
Starting from the right, we can see the lower border of the liver.
Yeah.
And you can see a kidney with.
Kidneys are seen. Kidneys are seen. Next. What are the other things seen? Then
Spleen we can see, ma'am.
spleen is seen. What else? Move on.
Anything else?
Yeah. Seen. seen in the pancreas. Bhargav, can you enlarge that? It's possible. I do not know. Yeah, that's good. Yeah, that's good.
Very good. So
That's
that's,
great. That's very
yeah.
good.
So now, what
Now
is there
then.
in the pancreatic head? Come on.
There is a hypodent lesion in the head of the plant.
So what is it? What is it? What are the possibilities? At least give some possibilities. VK can in fact. Can you just trace the stomach?
Stomach is on the.
Place it down and see what happens.
There is a duodenum.
Can you see the duodenum?
There is a narrowing in the D1, D2 junction.
You think there could be a narrowing. So, but what is that? The hypodense lesion. The pancreas. What are the possibilities? Give a DD. It may be related, it may be unrelated. That's how we discussed, no? Because we kept talking of liver abscess, but this may be related, it may be totally unrelated. So what are the possibilities? There's no evidence of pancreatitis. It can just be a simple cyst. Just give a DD, no? We are just asking a simple question. Just give a DDs. Just give few DDs.
This can be a pancreatic cyst since we cannot see any lobulation inside the
Sure.
cyst.
So one, it can be a cyst. What else? What are the other possibilities? What will be the position of the bile duct? Can it be because we don't have any other section, so we just have one here. And as Dr. Shobna was mentioning, there was something in the stomach and the duodenum, there's some haziness there. Whether there is something there, is it a mass lesion or is it?
Well, the duodenum is looks a little abnormal.
Bhargav,
Mass
next
lesion,
slide.
mass lesion
Next.
causing compression of the duodenum, ma'am. That can be one possibility in this case.
So mass lesion where? Can
Head
you
of the
magnify?
pancreas.
Can you magnify this one, the second one, Bhargav? Yeah. Yeah. Now. So it's the same thing magnified. No? So there is some indentation there, and now what are the possibilities in this patient with this picture? No vomiting, no loss of weight, no loss of appetite. From September onwards, he's having repeated drainage of the collection. So what do you think could be that collection? You think it's just a liver abscess that should have resolved? So what are the biggest tests that you would do in that abscess that you're draining? Any thought process?
Anybody wants to say
on one side is communicating with the pleura,
yes.
but on this side,
There's also an
What is it
obstruction.
doing? Is there something in the common bile duct area of in the pancreas, intrapancreatic CBD? Is something sitting there?
that is causing an upstream and causing it not to
Upstream
be.
dilatation.
There's something that's happening that's not allowing the abscess to resolve.
Correct.
Every time they're draining 200, 250, 300 ml. And so we also check for bilirubin. You have to check for bilirubin in that. So whether it's actually a fistula there communicating with the biliary system with an upstream dilatation. So I don't remember what value it was. Okay, move on to the next slide. Next slide. Okay, now describe this. Amit, you're the final year exam going or your
The final year exam going.
the second final? Then please speak. Yeah, Harish is talking all the time. We brought 4 of you. Please speak. Can you just take up this? Can you describe this now? Bhargav, just magnify it a bit, please.
You see
Yeah,
something
that's
there.
very good. Excellent. Yeah, beautiful. Amit. Abubakar and Amit.
What's happening to the bile duct?
Can you describe the findings, doctor? Please speak, doctor. You have to speak, doctor.
I'm sorry, ma'am. I'm not able to understand.
No, can you just no, don't get worked up. Just describe what is seen here. It's a coronal section. Start speaking. Only when you start speaking, you get the answer. So one is the coronal section showing
Dilated common bile duct we can see, ma'am.
Very good. Very good. Then what else?
There is there is
Abruptly,
abrupt cutoff to
abruptly
the
the end tapers into head of pancreas. Ma'am.
Good, excellent. Yeah. So there is so what is the relationship of portal vein to CBD? What is the relationship of portal vein, hepatic artery, and CBD? You can see it here. So what is the relationship? What is posterior and what lies anterior to the portal vein? And which is to the right and which is to the left? All these things you should know, doctor. These are all two basic questions, okay? So you're seeing here gallbladder. You can see a dilated CBD. And then what's happening? Can you see the abscess cavity there, right on top? What should be the next investigation? What should you do now? Amit, what would you do now? What would you do now? You have a smooth tapering of distal CBD. You have a portal vein, and you have an abscess in the upper portion. What would you do now? Simple question.
What do you expect? Why is it there's an abscess with a dilated?
Please don't answer in the chat box. I request you all not to answer in the chat box, okay? Please.
The mass lesion or the cystic lesion in the pancreas is compressing the CBD, ma'am.
Yeah,
It is causing the upstream dilatation.
The next investigation.
Endoscopic ultrasound.
Why endoscopic ultrasound?
Characterize the lesion and, if possible, take a biopsy from the pancreatic lesion.
Any other simpler procedure?
CT-guided drainage or biopsy.
No. There's a bile duct which is obstructed distally. There's some pancreas. And then what is it? Once you said, madam said, one is US. What else you will do to look at the bile duct for an obstruction? Another investigation, imaging you can do.
MRCP.
I think this picture here is as good as an MRCP, no? Yes. It's giving you all that you want is there. It's there. In few sections even showed dilated IHBR that was draining into the abscess. So I would not ask for an MRCP. Any other? Can you do an endoscopy first? Just an upper GI endoscopy? Would you like to do just an upper GI endoscopy and just see what's happening to the patient? So anyway, we did an upper GI endoscopy. Next slide. So this was the finding. So the CT abdomen showed hyperdense lesion 9:7:8. Rim enhancement. This is the description of an abscess. Rim enhancement. Collection of the cavity, which is communicating posterior segment of the lower lobe. So that's called a hepatobronchial fistula. Another lesion was seen 6:5. CHD was 1.37 centimeter. CHD. And CBD was 1.43 centimeter with a tapered end. Portal vein 1.49. Spleen was mildly enlarged. No ascites. Mild pericardial effusion. No pleural effusion. Next slide. Can you describe this?
What is this?
What is this approaching differential? You can reduce the size a little bit, Bhargav. There's a question on top. Bhargav is with, yeah.
If you see an endoscopic picture like this, what is your diagnosis?
The diagnosis.
Abu Bakr?
She's got, Jayanti, she's 50-year-old. No, he's
40, 51, 40, 48 or 51.
okay, fine.
Doctor, just tell you differential. Supposing this is kept as a spotter for you in your Viva, just think what will be your differential. We are not asking anything of the case. This is supposing this is coming as a spotter. There are a few things that come to your mind, no? Just tell you differentials. We're not asking.
Cystic neoplasm of pancreas.
Question. Sorry?
Cystic neoplasm of pancreas.
One. Okay. Then? They're not linking this to the case. I'm just asking.
Supposing is related to bile duct.
Bile duct, exactly.
So what is important here for the students is that the bile duct is dilated, but there is no IHBR dilatation. Look very carefully at the previous CT. You see the bile duct
Choledococele?
enormous.
Yeah, good. Choledococele. Yeah.
Very good. The choledococele.
Polydocus.
The other one is impacted stone. No? There could be a stone, you just do choledocotomy and the stone is delivered out. No? But the report came as a bulky pancreas. So what is this bulky pancreas? So we always keep
What is it
describing
due
this.
to?
What is this bulky pancreas due to? You know, we always use this term when we write an endoscopy. Ampulla looks bulky. So what is this bulky pancreas?
What is the possibility of a bulky pancreas in this patient? You've got a polydococele.
Maybe we can give the answer. We're running short of time.
You can have sometimes pancreatitis, no? So in a choledococele is type 3 choledocal cyst. So in choledocal cyst, you can have to recognition, you can have a pancreatitis, or sometimes you can have associated, what is it called? What is associated abnormality within choledocal cysts they can have?
Abnormal pancreatico-biliary union.
AB, anomalous pancreatico-biliary union. This one is recurrent pancreatitis. Even in the CT, you see the bile duct is nicely dilated in the around the pancreas.
And other important will be differential for a carcinoma pancreas, no? Ampullary carcinoma. Okay, next slide. Next slide. So this was the report. So it came as that particular lesion. They just did a biopsy. We didn't expect it. It was just a bulky pancreas because this side there was a cyst. But we were wondering there was a stricture with upstream dilatation and therefore the patient had abscess. Lo and behold, there was a moderately differentiated adenocarcinoma in that small lesion. Okay, so now tell how would you manage this patient, Amit? So now you have a surprise of a surprise that this is coming as moderately different adenocarcinoma. You want any further investigations? So on the other side, you have a pigtail drain with the abscess being drained. So how should you manage this patient? What will be your, and CT showed no nodes. There were 1 or 2 nodes around the porta. There were no other nodes, no vascular invasion, no, and mind you, it's going on from September of 2021. So what should we do? How should we manage this patient? Very simple.
Choice of surgery would be Whipple surgery, ma'am.
Good. So you'll ask for a Whipple's procedure. Exactly. So Whipple's would be the. So what are the components of Whipple's?
Removal of nowadays pylorus preserving Whipple's is done, in which pylorus is preserved. The duodenum will be removed along with head of pancreas along with CBD.
And what are the 3 anastomosis?
Anastomosis.
Hepatojejunostomy will be done.
Hepaticojejunostomy.
And
Pancreatico-jejunostomy.
Pancreatico-jejunostomy.
And
jejunojejunostomy. And learn to draw these figures. Examiners ask these questions. You have to draw the diagram first with intact, and then whichever ones you resect, and where do you take the jejunum. All these questions are asked because when you do an endoscopy later, you should know the anatomy. Okay. So this patient underwent surgery about 4 days back. Next slide. Now, what's your complete diagnosis in this patient? Just answer quickly all these 4 questions. So all these questions will be asked. Your complete diagnosis, because now, so the exam, you'll be discussing all along liver abscess, and suddenly they put up these questions. Then you'll have to consider how to explain this particular abscess. It looks more like a pressurized chamber causing cholangiolitic abscess that was draining through the pleura and causing hepatobronchial fistula. That's what we presume, okay? And how do you manage bronchopleural fistula will be essentially the drainage. Role of levers and MRCP, you should know. Amit did mention a few points on that. But in this particular case, since we got the tissue diagnosis with a forward-going scope,
EUS can be avoided.
Further. Yeah, otherwise EUS would have been an ideal procedure and you could do, but not a CT guided, never a CT guided. And then management of ampullary carcinoma. Now, in this particular patient who's got nothing else, you think, what are the other options for an ampullary carcinoma? Dr. Shobana and LVK, just take up this last question. What are the other options available for management of an ampullary
let's say
carcinoma?
he has got an EF of 30%.
Yeah, EF of 30%.
Let's say he's got an EF, he's diabetic, he's got coronary artery disease, EF is 30%. You have a small ampullary carcinoma. Then you don't have notes, you don't have any
Nothing is
involvement.
and everything available at the center.
Is there an endoscopic option available for treatment?
Yeah.
Ampulectomy can be tried.
Ampulectomy.
You
Yeah.
do ampulectomy and then do a
Then what do you do?
biliary drainage, no? There's a dilated system, so you need to do whenever you do an ampulectomy, you need to put a
Drainage.
drainage.
Drainage. Exactly. And other few questions take off would be screening of the colon. If the person was younger, for other polyps elsewhere in the colon. Okay, so ampulectomy is something in some of the best centers. In fact, I sent one patient to Dr. Nagi. What he did was he just placed a band, Nowadays it's a band ligation and it drops off. You don't have to do anything. They don't even do an ampulectomy. So I asked him, what about ampulectomy? He just says you just put a band and it just falls off. The ampulla just falls off. And then they do a drainage. Okay, so please read about just a small, the lesion is hardly ever seen, it was just a small bulky pancreas. And they picked up this in this moderately differential adenocarcinoma. So read all the things that you
Early malignancy.
that will hover around the ampulla. All right. So the next slide. So can you see the lesion? This was a resect specimen. The size is just about maybe less 0.5 centimeter or so. We're waiting for the histopathology. Real small, tiny lesion causing so much of a havoc. There's something as liver abscess. So in the exam, just be careful if you get a hint by the registrar saying it's a liver abscess with ampullary carcinoma, you will not be able to make a diagnosis by history taking. It's only after imaging that we thought that this was a possibility. And then we went forward for an endoscopy. Due to economic constraints, we went for an endoscopy first. Fortunately, it picked up and the patient next day was taken up for surgery. Okay, so what are the learning points in this patient? Learning points are liver abscess. It can always need not be pyogenic or amoebic. You can get these cholangiolitic abscess. We'll ask you differences between liver abscess,
Amoebic and cholangitic.
Cholangiolitic abscess. And in sepsis, you can get multiple. So difference between liver abscess of amoeba versus cholangiolitic abscess of sepsis. You should know the differences. And then all this, that we kept asking the history of cough. So sometimes when there's a pleural reaction, they can get cough. But here it was actually something that was communicating with the hepatobronchial tree, and he had little cough. He was a little sick that side, go towards the abscess side. There was no pruritus, nothing, because it was draining to the other side. So patient had no symptoms, no jaundice, no pruritus, nothing. Okay, so but this is for discussion. So when they put up the slide, you should have an open mind. I even thought whether it was one of the choledochal cysts because it was quite dilated. The type 1, the fusiform dilatation of the CBD. Then they said there was IHBR dilatations. And I said, okay, it's unlikely. I even thought of Carolese. So all these differences just come to your mind, what is happening in this patient. But then they said there was this narrowing at the end. That was the one that made us think, okay, there is an actual organic obstruction that is causing the problem. So the plan was to go first for EUS, first for forward doing due to economic constraints, and then proceed for the next level would be US, and then let's do whatever is possible. Okay, LVK and Chopra can give some
sometimes
points.
in the ward rounds. This is predominantly, the discussion was predominantly on the liver abscess. I think this was the end of the time. Then we picked up ampullary carcinoma, but even sometimes we keep liver abscess in the ward round brain. With a drain, so kindly know about cholangitic abscess, pyemic abscess, and amoebic abscess. How do you treat liver abscess? What is cholangitic abscess? And what are the causes of pyemic abscess? Appendicitis, diverticulitis, perforated ductus, all those things. And you should know completely what is the treatment remedies for how long you give antibiotics in cholangitic abscess or in a pyemic abscess. And you should also know how do we treat about amoebic abscess. Amoebic abscess is something which I think Shobna might tell us that we all expect a lot from amoebic abscess. You should know everything in amoebic abscess. Why do you get? Is amoebic abscess more in toddy drinkers or in the patients who take whiskey and vodka? Anybody can answer this. Very important question.
Yes.
You see a lot of alcoholic hepatitis people come, but you don't see them with amoebic liver abscess.
Yes.
But you see people on the other thing, they take, I think when I studied in Stanley Medical College, every night there'll be some 3 patients amoebic liver abscess. It is basically industrial area. Most of it is toddy drinkers. Why is it you get amoebic abscess in toddy drinkers, but not people who take whiskey and vodka? Important, very, very important thing, because I think there's one beautiful paper from Sri Lanka. Then you should know that the iron content in toddy is very, very high. So with iron content, amoebic trophozoites, actually they feast on the iron. That's why it is more on this one.
Very nice point. Excellent.
Yeah,
How do you
that's very-
differentiate maybe? That is actually why that's why I think Madam will also, I studied in Stanley in my MBBS, and Madam was there. The whole of North Madras night, if somebody comes with jaundice, upper wandering and taking toddy, you have an intercostal tenderness, which is almost always liver abscess. We didn't have ultrasound, we didn't have thing. We used to put a needle or prothrombin time, nothing.
Nothing.
Needle,
Nothing.
you get 1 to 1.5 liters of pus. Then before the night, I think my chief MS Ramchandran comes, you have to put in a air and take an X-ray. Then you will see on abscess cavity. That's all. The diagnosis
Yes, we've done all that.
right upper quadrant pain in a toddy drinker with jaundice and intercostal tenderness. If you look at the Western books, they will not mention jaundice, but I think Dr. NMG's paper and Dr. B.S. Anand's paper, they
Yeah,
say
and BML Kapoor, no? BML Kapoor. BML Kapoor has a monograph on amoebic liver
amoebic
abscess.
liver abscess. They say that the jaundice is also seen in these.
They
You
are-
should know
they-
all
they-
about amoebic
yeah,
liver.
they
How
should
do you
everything.
treat, and what is the complications of a left side abscess and a right side abscess? Okay, all those things.
And metronidazole, how much do you give?
Yeah.
How do you give
How do you
750
give?
milligrams? How do you give 750
Then
milligrams?
how do you give luminal amoebicides?
And
All those
luminal
questions will be asked.
And what is amoebic dispar, dysentery, everything about amoeba. Absolutely essential. Shobna, thanks for joining. And
Yeah,
few tips.
Just
They're all exam going. Yeah.
last one is that in a patient whose amoebic abscess or whatever abscess is there is not healing despite multiple drains,
Yeah,
look
that's
for a distal obstruction
Yeah.
or look for a connection with the biliary tree. And in this case, that is exactly what's happened. And that is why the IHBR was not significantly dilated.
Yeah, it was getting
Everything was
decompressed.
going into the drain. So that's an important learning point in this. So very good case.
And after surgery, the drain is now only 10 ml, from the, because that is, the hepaticojejunostomy has drained that. So by God's grace, he's doing well. He should be out tomorrow.
So you should know what are the causes of liver abscess. So you need to say about amoebic. You need to talk about pyemic. You need to talk about cholangitic. Can you get abscess after post cholecystectomy? Supposing somebody has come with a post cholecystectomy, bile drain is about 500 ml and his enzyme is 8,000, SGOT is 8,000, SGPT is 7,000. Importantly, if you hit the hepatic artery and cause an hepatic thrombosis, that segment of liver will become like an abscess. And then these are the things which you know about. Most biliary strictures can come with recurrent cholangitis and cholangitic abscess. HIV cholangiopathies sometimes can come with PCC, all those things we should know. So I think it's a broad topic.
Thank you, Enrique. Thank you, Shobna.
Thank you. Thank you.
Yeah. Nice
Yeah.
session and nice discussion.
Yeah, very good session.
But
Very
both are like exam cases, no? Both
Yes,
almost-
very good.
Yeah.
Yes.
And basically the questions will just hover around like this, because it's like your first case, again, history was going towards kidney, but investigations came, and likewise this case, no? History was going towards liver abscess, and then suddenly we found out something else.
Yes.
And it's just providential that picked up the lesion. If it had come as inflammatory mass, then again we would have gone into a problem as to what it was. Thank you very much.
Thank you.
Thank you and good night.
Bye.
I think there were some questions in the chat box. I did not bother to see that. I don't know if there are any. EUS, why not CT guided drainage? CT guided drainage, I don't know. Dilated intrahepatic CBD, right? Pancreatic necrosis, biliary pleural fistula, AMA we have discussed. MPV also we have discussed. And then splenic vein thrombosis. I think most of the questions we want. Any questions anyone wants to ask and raise their hands? Just another 1 or 2 minutes. Anyone in particular? You can just raise your hand. Hitesh, yeah, can ask the question. Hitesh, you can ask the question quickly.
Yes, ma'am. The HVPG was normal, ma'am. First case. Usually, NCPF, little
HVPG was
HVPG.
high, no? 20.
20.
But
20
it will be
high.
normal in.
In NCIPH, it will be between subclinical and clinically significant because it was pre-sinusoidal. So normally you would expect around 8 or 9, but here it was really high. So all these NCIPH